Okay, this is our brief lecture on gender dysphoria. So this represents a change from the DSM-4. You have probably heard of gender identity disorder, which was from the DSM-4. DSM-5, with the help of researchers and clinicians who have worked a lot with um, the transgender, gender nonconforming, gender expansive, gender queer community, um, really to make sort of a change of focus in the gender dysphoria diagnosis. Um, so, what we're talking about here in terms of this change, we're talking about diagnoses here in terms of gender dysphoria that are characterized by distress that may accompany the incongruence between one's experienced or expressed gender and one's assigned gender. The key part of this that's really important is that the move there's a move away from the problem being the incongruence itself to the problem being the dysphoria that is experienced as a result of the incongruence. This is a really controversial diagnosis and really important to kind of keep that in mind. Um, what is likely obvious to you is that if we had more space when it comes to gender, if we kind of did gender a little bit differently in the world, there probably would be far less dysphoria. That really the dysphoria arises um, in relationship to really oppressive contexts in which individuals who are trans or genderqueer, or gender expansive, or gender nonconforming, the spaces that they move through, these individuals move through. And so I just want to really name, as we talk about these two diagnoses, the really important fact that, this is certainly, like some of the other diagnoses, a clinical picture where it's very difficult to, in many ways, identify and locate the quote unquote pathology inside of the person, where really there is a large cultural pathology that exists. So the DSM provides some uh, um, criterion for gender dysphoria in children and then also in adulthood, adolescence and adulthood. So for children, these are the criteria here. You have an incongruence between experienced or expressed gender and assigned gender for a minimum of 6 months that manifest in 6 of the following, one of which must be number 1. So number 1 here is a strong desire to be of the other gender, or a child's insistent that he or she or they is the other gender. So that's a part of the picture. That has to be a part of the picture to qualify for the diagnosis. You have a strong preference for cross-dressing or simulating cross-gender attire, a strong preference for cross-gender play or fantasy, a strong preference for toys, games, activities that are stereotypically associated with the other gender, a strong preference for playmates of the other gender, strong rejection of toys, games, and activities that are typically associated with the assigned gender of the individual child, a strong dislike of one's sexual anatomy, strong desire for the primary and secondary sex characteristics to match one's own experienced gender. And most key in all of this is that this experience in criterion A causes distress, and that distress is the dysphoria that we're talking about. Now, sometimes in treatment planners, you have reference to sort of the non-current, non-most sort of up-to-date approach to intervention with children with gender dysphoria, where you might see a goal in a treatment planner that is to help the child move towards gender expression that is consistent with their sex or their assigned gender. Um, the treatment planning notes here and interventions to consider here really align more with kind of current practice, which is really not about helping the child to move to a gender expression that is consistent with assigned gender, assigned sex, but really to address the difficulties and the distress that's associated with the gender nonconforming behaviors. So really important that we have a thorough assessment of the history and severity of the dysphoria itself. How much pain has this caused the child, and is it currently causing the child? Supportive individual and family therapy to explore gender expression safely and to mitigate shame reactions and their effects across settings. This can be done individually with the child, but also, of course, must involve the family as well, as the family kind of transitions and works towards really supporting their child. Addressing coexisting mental health issues as needed. There might be comorbid anxiety related issues, comorbid mood related issues. Psychoeducation and support group referrals for children and for family members. Lots of these are peer run, family run support groups out in the community, put together by families who have children who are trans in some way. Conjoint therapy for parents to foster supportive stance towards their child and to process their feelings and concerns. So this is one of those areas where parents certainly have to go through their own process, and that sometimes involves a whole range of different feelings that really, that often parents need support around. Advocacy on behalf of the child and family, for example, in schools or with medical providers. Assisting in preparation for and the navigation of social transition. So really helpful, a helpful role that a clinician can play is to really support the family and the child to prepare for any kind of social transition that the child is going to make in various settings where the child, various spaces the child lives in. Referring for pediatric endocrinologist as needed in preparation for possible medical treatment when puberty begins. So as you're probably aware, really there is no medical intervention that occurs in childhood. The transition process is primarily around social transition. But as the child begins to near puberty, discussion about the possibility of starting puberty blockers can be quite helpful. I'd just like to mention here that research basically shows that somewhere between 6 and 23%, so you can get different numbers based on different research, 6 to 23% of children with gender dysphoria actually go on into adulthood to actually end up identifying as a trans person. Most children who experience gender dysphoria, cross-gender affinity, actually end up gay or lesbian, possibly bisexual as well. That is to say, only about 6 to 23% end up longer term actually being trans, and again, this is among child populations. For adolescents, though, adolescents who express cross-gender affinity in this way and identification, it's much higher, much more likely that the adolescent will move into adulthood and adopt a trans identity. So in terms of the diagnosis in adolescents and adults, criterion A here, we have an incongruence between experienced and expressed gender and assigned gender for a minimum of 6 months, manifesting in 2 of the following. So where there are 6 total, we have an incongruence between experienced and expressed gender and primary and or secondary sex characteristics. Strong desire to be rid of primary and or secondary sex characteristics. Strong desire for the primary and or secondary sex characteristics of the other gender. Strong desire to be of the other gender or some alternative gender to one's assigned gender. Strong desire to be treated as the other gender. and strong conviction that one has the typical feelings and reactions of the other gender. Now, again, that is not the pathology. The pathology is the distress and impairment that this causes. I just want to mention here briefly and you are probably already aware of this, but primary sex characteristics that we're talking about are sex organs of reproduction that are present from birth, things like chromosomes, testes, uterus. Secondary sex characteristics are those that arise out of puberty, so things like breasts, facial hair, body hair, things like that. Similarly, in terms of interventions to consider when working with individuals who would meet the diagnostic criteria for gender dysphoria, thorough history as well, really important. Clinical problem solving, CBT, and supportive approaches to support changes in gender role and expression and social transition. Working with individuals to address the anxiety that comes up around that, to really kind of problem solve and develop a plan for that social transition process. Addressing and processing disclosure issues as they arise, addressing and processing interjected messaging and gender scripts and related shame, exploring sexual identity issues, which can sometimes arise. I just speak personally in my practice. Many of the individuals that I've worked with who are trans-identified, some with and some without gender dysphoria, during social transition and medical transition, typically a really important part of the process is really exploring and understanding in a new and perhaps deeper way sexual identity, which for some individuals becomes a little bit more fluid. Address where needed body dysphoria. Body dysphoria is something that is quite common among individuals who have gender dysphoria and among individuals who are trans in general. Really helpful to work with individuals from a variety of different perspectives, kind of processing and challenging some of the distorted perceptions and thoughts that exacerbate and maintain dysphoria. Psychoeducation on medical interventions, preparation for the client and referring for medical evaluation, and as the person's ready, initiation of medical care. This can be things like puberty blockers or inhibitors, hormone therapy, gender confirmation surgeries like top surgery, bottom surgery, feminizing procedures like facial surgeries, things like that. Advocating for the client's appropriate care with insurance companies, for example, to cover the cost of care. This is where a diagnosis of gender dysphoria can be actually quite helpful. In order for a client who has insurance to have any of their care, medical treatment paid for, and also mental health treatment paid for, a diagnosis of gender dysphoria is required. Processing and empowering the client around issues related to the experience of transphobia. Certainly clients who come who are trans-identified in some way often usually have long histories of experiences with transphobia, and it's really important to work with that, to elicit that, to broach those topics with clients, and to really create a space where the client knows that they're really welcome to and you would really want them to talk about those experiences. Addressing and processing internalized transphobia and referring for trans support groups. I think, particularly if you are a cis provider, there's something just really, really potent. I hear this from client after client, something really, really potent about connecting with their community, which I can completely understand and really support. So this is from WPATH, the World Professional Association for Transgender Health. Just a quote that I like here. The general goal of psychotherapy is to find ways to maximize a person's overall psychological well-being, quality of life, and self-fulfillment. Psychotherapy is not intended to alter a person's gender identity. Rather, psychotherapy can help an individual to explore gender concerns and find ways to alleviate gender dysphoria if present. Typically, the overarching treatment goal is to help transsexual, transgender, and gender nonconforming individuals achieve long-term comfort in their gender identity expression with realistic chances for success in their relationships, education, and work. Psychotherapy may include clarifying and exploring gender identity and role, addressing the impact of stigma and minority stress on one's mental health and human development, and facilitating a coming out process, which for some individuals may include changes in gender role expression and the use of feminizing and masculinizing medical interventions. I just appreciate this in terms of identifying and kind of defining our role as clinicians, and also how it emphasizes our role in co-creating with the client a an exploratory space where identity can be explored and opened up, and that is not necessarily in all cases leading to any kind of medical intervention, but really about creating and opening up a space for someone to really explore and understand and live into all of who they are. All right, that concludes our brief lecture on gender dysphoria.